Good afternoon, everybody. Welcome to the 33rd Annual Miriam Lemberg Visiting Professorship. My name is Joshua Hare. I'm the Lewis Lemberg Professor of Medicine. It's my honor to have you all here and introduce this lectureship now in its 33rd year, so a third of a century and going. I'd just like each year to give a brief history of the Lemberg family. First of all, I want to welcome the Saltzman, Paula, Alan, Russell, and Xenia. Paula is Lou and Miriam's daughter. The Lewis Lemberg Professorship was endowed around 1990, and I've been honored to hold that chair for the last 19 years. The chair was assembled by Miriam, presumably without Lou knowing anything about it. And Lou, at the same time, was doing something to honor Miriam without her presumably knowing anything about it. And he put together the endowment for the Miriam Lemberg Visiting Professorship, which has enabled us here at the Miller School of Medicine to invite literally the creme de la creme of the leadership of cardiovascular medicine to visit us on an annual basis. So that's the history. It's a thrill to be in our 33rd year. I'd like to turn it over for the introduction of the speaker.
It is my pleasure to introduce Dr. John Keaney, Professor John Keaney, who is the Chief of Cardiovascular Medicine and Executive Director of the Heart and Vascular Center at Brigham and Women's Hospital. Dr. Keaney graduated from Harvard College with a degree in biochemistry and molecular biology. He then received his medical degree from Yale University School of Medicine, and then he returned to Massachusetts to complete his internal medicine, cardiology, and interventional cardiology at the Brigham and Women's Hospital and Harvard School of Medicine. He then started on as faculty at Brigham and Women's, and then he moved to Boston University in 1994, where he rose to the rank of Professor of Medicine in 2003, and he subsequently became the Vice Chairman of the Department of Medicine. Dr. Keaney then joined the University of Massachusetts School of Medicine in 2007, and he remained there until he made his move back to Brigham and Women's in 2019. Dr. Keaney's laboratory has defined how blood vessels resist injury from conditions such as high cholesterol, high blood pressure, and diabetes. His studies include over 230 publications that have provided critical insight into why only certain patients develop heart attacks and how vascular disease can be treated and reversed. His work has been recognized by election into international honor societies for physician scientists, such as the American Society of Clinical Investigation, for example. He previously served as the associate editor for AHA Journal Circulation and was the founding deputy editor for the Journal of American Heart Association's Open Access Journal. He currently serves as the cardiovascular associate editor of the New England Journal of Medicine. Please help me welcome Dr. Keaney as he talks about endothelium in health and disease.
Thank you very much for that overly kind introduction. I would say I'm deeply honored to be here for the Miriam Lemberg Lectureship, a visiting professorship. In particular, my wife is very happy about it because behind every successful person is a great spouse. And in my hometown, I'm known as Donna's husband. So it's quite fitting that Dr. Lemberg put so much effort into honoring his wife. So let's move ahead. All right, well, at least I can do this, I think. Let's make sure. Now it is. Let's see if it'll work now. So what would I like to talk about today? Today, I'm going to talk a little bit about why I've focused in my career on the endothelium. We'll also talk a little bit about what the consequences are when the endothelium isn't up to its normal function, and also its relevance to human disease. This will be a little bit of a historical tour. And then we'll talk about the reversibility and causes of dysfunction of the endothelium, and then how our concepts have changed. And then give you a little bit on some new takes on how we think about things, particularly in the clinical realm. So one of the things that came to light in the early 1990s is that coronary events are really not necessarily derived from progressive stenosis of arteries. And they're often derived from the less severe stenoses. And this is a series of studies that was reviewed by Dr. Fuster. And these were studies that happened to have antecedent angiograms before patients presented for a heart attack. And they looked at the grade of the stenoses in the artery that caused the heart attack. And you can see that about 2/3 of the heart attacks were caused by stenoses that were less than 50%. And we understand now that the reason for this is due to what's called the Glagoff phenomenon. And this was a study published in the New England Journal in 1987 that was comprised of histologic sections of hearts at autopsy. And Dr. Glagoff found that one of the circumscribing definitions of the artery, the internal elastic lamina, correlated with the area of the lesion. And as you can see here in the figure, there's an increase in the size of the artery as the lesion progresses, and it's only late in the disease that it starts to encroach on the lumen. And so one can be surprised that you can have a lot of atherosclerosis without having a very significant stenosis. And shown here is an example of that. So this is an angiogram, and an angiogram we have 2 points, A and B. They look to the naked eye very similar, but if you happen to put a catheter inside the artery and you take an ultrasound picture, which is basically a slice of the artery, in B, this is what a relatively normal section of artery looks like. And it's got a circumscribed area. But if you pull the catheter back just a little bit and look at section A, you have the exact same area. So no obvious stenosis, but shown here is this very large atherosclerotic plaque. So you can have a lot of atherosclerotic burden and a lot of plaque, and it doesn't necessarily show up on the angiogram. Now, our concepts of coronary artery disease activity have come to involve more than just the presence of a stenosis. So we have the stenosis, which is one of the underlying mechanisms, but then we also have plaque rupture, platelet activation, and then thrombosis, as well as downstream vasospasm. And the reason I have these latter 3 components in red is because these are things that are under the control of the endothelium on a moment-by-moment basis. And it's one of the things that got me interested in my career in the endothelium and its function. So what are the consequences of these dynamic changes that are due to the endothelium? So this is a study that was done in the early 1990s by John Gordon. And this is actually a technique where you look at a coronary angiogram while you have people exercise on the catheterization table. And you can see here in exercise, the coronary artery diameter actually increases in response to the exercise, an autoregulatory mechanism. And you can look at how much you can get the artery to dilate when you give some nitroglycerin. And that's in the smooth segments of the arteries. But if you look at the irregular or the stenotic segments of the arteries, actually things constrict when you exercise. They actually don't dilate normally. And we'll talk in a moment about what the reason for that might be. But this was one of the first inklings that arteries are dynamic, they respond to demand, and that there may be something different about the arteries if they have disease in them. There have been a series of studies that were done thereafter. Shown here is the alma mater of Dr. Hare and myself for our cardiology training, the Brigham and Women's Hospital. That's actually where these studies were done. And with manipulations like exercise, mental stress, sympathetic activation, and increases in blood flow, all were demonstrated to cause inappropriate constriction of the arteries. So abnormal function. So the question is, how does this work? So one of the systems that we now know is a major contributor to the function of blood vessels, and it's derived from the endothelium, is the endothelial nitric oxide synthase cyclic GMP axis. And we abbreviate endothelial nitric oxide synthase as ENOS. And you can see in this figure, there's an enzyme in the endothelium, which actually takes an amino acid, L-arginine, and converts it to a short-lived species, nitric oxide, that then can diffuse from the endothelium to adjacent tissues and affect homeostatic responses. And what do I mean by that? I mean limitations of platelet activation, increased oxygen delivery from red blood cells to the tissue, limitation of leukocyte trafficking and adhesion through the tissue, as well as smooth muscle cell relaxation. And these are all paracrine responses for the arteries. And the mechanism by which this occurs is through the interaction of nitric oxide with a heme moiety in the enzyme soluble guanylyl cyclase, which is shown on the bottom of this figure. And this is a figure from Mike Gembroni, who was the first person to describe the fact that the endothelium is actually dynamic and is involved in an inflammation. So is this system relevant to the coronary arteries? So this is an angiogram from my late colleague, Joe Vita, where on the left side, under baseline conditions, the angiogram shows the normal coronary artery, and that happens to be the circumflex coronary artery. And it's known now from experiments in isolated vessels and endothelial cells that if you tickle those cells with acetylcholine, there's an interaction with the receptor that causes the elaboration of nitric oxide. And you can see in this slide that there's quite a bit of dilation of the circumflex coronary artery. So this is actually the endothelial nitric oxide synthase cyclic GMP system working in the coronary, in human coronary arteries. So what happens when the system doesn't work normally? Well, when the system doesn't work normally, you end up with less nitric oxide generation. You end up with more leukocyte adhesion, more platelet activation, and more constriction of the artery. So an example of that is shown here, and this is again human coronary arteries in the catheterization laboratory, and shown on the left is normal left anterior descending coronary artery. Usually when there's a figure that has arrows, it's always a good idea to follow the arrows. They show you where the action is happening. And if you look at the arrows on the right, you can see what happens when acetylcholine is infused into this patient who has actually abject coronary artery disease. There's actually constriction. And that's part of the fundamental response that we saw on the previous figures that showed constriction of irregular and stenotic segments of the artery. So is this relevant to human disease at all? So it turns out that we can actually measure how the endothelium functions without having to instrument your coronary arteries. One of the stimuli that elaborates vasodilation is increased blood flow, just like the exercise that we saw. And that produces a tractile force on the endothelium, shear stress, that causes elaboration of nitric oxide. So we can actually test that in people's arms using ultrasound. And to sort of talk about a body of work, you can either test it in the coronaries, like we showed you on the pictures, or we can test it in the peripheral studies in the arm. And this is a series of studies that were done in patients over the course of months, shown on the left side, to test their endothelial function, their vascular function. And if they had normal or abnormal function, they were then followed over the course of the number of months that you see, and looked and followed to see if they had cardiovascular events. And as you can see, the patients who had abnormal function of the endothelium had an elevated risk ratio for coronary events. And this has been, as you've seen here, in a number of studies, and it's been reproduced numerous times. So the conclusion is that if your arteries are functionally impaired, and we'll talk about some of the reasons why that might be, you're more prone to have vascular events. So what are the causes of this abnormality? So there's a number of possible causes, but one of the main ones is that when arteries are injured or arteries are exposed to injurious stimuli, they often produce superoxide, a reactive oxygen species. And I'm not planning on turning this lecture into chemistry class, but reactive oxygen species combine very readily with nitric oxide and inactivate it. it occurs at the diffusion limit, and it ends up reducing the normal bioactivity of nitric oxide. And this has been observed in a number of conditions that are known to be injurious to blood vessels, like hypercholesterolemia, smoking, types 1 and 2 diabetes, hypertension, and coronary artery disease. And not included here on the slide is one of the conditions that Dr. Hare studies, which is cardiac dysfunction. There's also limited function of the endothelium when the heart is not working normally. So then the question is, can you reverse this? Is there anything we can do that can make arteries function better? And I happened to take a look at some of the work that had been done by Dr. Lemberg, and I was able to find one of his papers where he actually looked at vitamin C, or ascorbic acid. And one of the things that not everybody knows about vitamin C is it's an extremely potent antioxidant, and that it's actually concentrated inside cells. And I was able to find the importance of vitamin C in the incidence of atrial fibrillation. And we can see this is a paper by Dr. Lemberg and one of his colleagues. So it just so happens that we took advantage of the fact that you can give vitamin C to patients pretty easily, that most patients who have vascular disease have relatively low levels of vitamin C. And this has been done now in a lot of patients, predominantly looking at the in the forearm, but some coronary studies. And overall, almost all the studies, when you give a supplemental dose of vitamin C, which would then potentially have an effect on the endothelium, you end up with a positive response, an improvement in the vascular function. And I won't go into too many details, but we were able to identify why that happens. And the bottom line is one of the major cofactors for producing nitric oxide is preserved when you bolster the cell with vitamin C. And we were able to demonstrate that in cultured cells. So then the question is, what are the clinical consequences of maintaining normal function of the NO cyclic GMP system? So it turns out that with modern genetics, we have been able to find abnormalities in the NO cyclic GMP system that are due to gene changes. And we can actually look at those patients and see if they have manifestations of vascular disease. So this is really the proof positive that the function of the endothelium has consequences for patients. And I'll give you two examples of the studies that have been done. This is the first one, which is a paper that was published in Nature. And shown on the left panel, you can see an extended family pedigree of a family that had lots of myocardial infarction. So the proband is here, and all the blackened in individuals had some manifestations of cardiovascular disease, most of which were myocardial infarctions. So the investigators in this study went and sequenced all the individuals, and they found two separate mutations throughout the family in the cyclic GMP generating enzyme, soluble guanylyl cyclase. And as I was telling Dr. Hare earlier, this is the only Western blot I have in this entire presentation. So I'm not here to turn it into a basic science talk, but you can see in the right-hand panel, the mutations that exist, two separate ones, one here and one here, are associated with a decreased amount of the protein, which is shown graphically on the bottom. So both mutations decrease the amount of protein that makes the cyclic GMP after being stimulated from nitric oxide. And an example of that is in this upper right panel, C here, where there's normal production of nitric oxide and then normal production of cyclic GMP to nitric oxide, but it's abnormal when you have less of the protein. And it turned out the idea being that if you don't have intact signaling of this system, you're more prone to cardiovascular disease. So this was also investigated by another group. This is from Connor Emden and Sek Kathirasan. And these investigators looked at two variants in the endothelial nitric oxide synthase gene and the soluble guanylyl cyclase gene that increased their expression at the mRNA level. And their strategy was to see if the increased expression had effects in the vasculature that were demonstrable. You can most easily do that by looking at their effects on blood pressure. And then they went on to examine the implications for cardiometabolic diseases and also for cardiovascular disease. So I'll show you that now. So shown here on the left is the expression of the mRNA with the two mutations in question. And you can see that both in aortic tissue and in lung tissue, both of those single nucleotide polymorphisms were associated with increased expression of the genes. And shown on the panel at the right is the biopsy of whether it's having a physiologic effect, what's happening to the blood pressure. And in both instances, having the presence of these single nucleotide polymorphisms was associated with a decrease in the blood pressure. So pretty good evidence that there was a physiologic effect of these two mutations. And in fact, they were also associated with better kidney function, an increase in the eGFR. So again, pretty good evidence that these had not only expression significance, but functional significance. But then to really nail things down, you can go ahead and look at certain cardiac diseases. So shown here is a list of cardiac diseases, and you can see that coronary heart disease and stroke and peripheral arterial disease were both less common in people who had these mutations that increase the endothelial nitric oxide synthase pathway. So with a decrease in the pathway, which we saw in the first study, you had more coronary heart disease and cardiovascular disease. And with an increase in the pathway, genetically shown here, there was a decrease in the manifestations of coronary disease and vascular disease. So pretty good evidence that this pathway does play an important part in the development and the clinical manifestations of vascular disease. So now we know there are a bunch of interventions that improve cardiovascular outcomes are also associated with improved function of the endothelium, lipid lowering, smoking cessation, exercise, et cetera. So even further linkage between behavior of the endothelium and the clinical manifestations of disease. So paradigm existed based on all these observations that are presented to you so far, that on one side you have the good guy, nitric oxide. That's associated with things like vasodilation, platelet inhibition, normotension, et cetera. And on the opposite is the bad guy, the reactive oxygen species, which is more associated with things like vasoconstriction, thrombosis, and high blood pressure, and poor function of blood vessels. And the idea is that one eliminates the other, and that's one of the reasons why you manifest vascular disease. But it turns out that life is a teeny bit more complicated than that. Because not all production of things like reactive oxygen species are created equal. It turns out we all have a classic enzyme that produces reactive oxygen species, and that's the neutrophil oxidase. And in fact, the lack of this oxidase is associated with the clinical disease, chronic granulomatous disease, which is manifested as excess infections. But through work in the early 2000s, it's turned out that there's actually 7 different types of NADPH oxidases in the body. Some of them are associated with, again, fighting infections, but some of them, we weren't 100% sure what they did. And what I'll do now is just show you a very tiny bit of work that's associated with one of them, which is called NADPH oxidase 4. And it's a little unusual compared to its brethren, so to speak, because instead of producing a free radical species like superoxide, it actually produces hydrogen peroxide, which is a different type of reactive oxygen species that has a bit of a different chemistry. So we actually wanted to know whether this could be beneficial, in part because one of the places it's most highly expressed is the endothelium, which was a little bit backwards for us. And we found that this protein was upregulated in the setting of hypoxia. And one of the manifestations of hypoxia is when you have, for example, peripheral disease and your muscles don't get enough blood. They produce growth factors and end up generating more blood vessels. And And we found under those circumstances, when we did this in an animal, that actually the amount of this oxidase was upregulated, which was surprising to us. This is a bit of a model system. I won't go into too much detail, but one can look at blood flow recovery in experimental animals using how much flow there is with Doppler techniques. And you can also measure how many capillaries there are after tissue injury. And so we actually made a mouse that overexpressed this oxidase. And lo and behold, it actually improved the recovery of blood flow after experimental peripheral arterial disease, which is shown here. And it also was associated with an increase in the amount of endothelium in the ischemic tissue, which is shown on the right-hand panel. So increasing the amount of this oxidase actually had a beneficial effect as opposed to the previously predicted abnormal effect. And a different group had two other models that actually had a decrease in function in this oxidase. And that decrease in function in the same model showed significant loss of blood flow recovery. So pretty good evidence that not all reactive oxygen species are created equal, and that actually there's some benefit to some of these. We went on, and I won't bore everybody with the details to see how this works, but to make a long story short, it turns out this reactive oxygen species turns on the nitric oxide pathway. And so the model is that it activates nitric oxide synthase and it produces vasodilation and angiogenesis. And I'll bore you through all the Western blots, et cetera, that actually show that. We then said, well, what about atherosclerosis? Since we know nitric oxide seems to be involved in atherosclerosis. And so you can look at a model, again, in mice. Many of us are both mouse doctors and human doctors at the same time. And it turns out that when you have this beneficial reactive oxygen species, you actually have less atherosclerosis. This is the aorta of a mouse that's fed a cholesterol diet. And this is the aorta of a mouse that has extra NADPH oxidase isoform 4. And we were able to demonstrate that there was a significant decrease in the amount of atherosclerosis that occurred. And if you delete it, this was published by two other groups, there's actually an increase in atherosclerosis. So again, more evidence that this type of NADPH oxidase is actually beneficial. So what sort of things have we talked about so far? So endothelial function is an important determinant of vascular homeostasis. Impairment of your endothelium is associated with an increase in cardiovascular events. And if we're able to preserve this axis, as demonstrated in a number of genetic studies and pharmacologic intervention studies, it's associated with reduced cardiovascular events. And this notion that oxidative stress is bad is a little bit contextual, because in some cases it actually serves a signaling function, and in other cases it can be a manifestation of disease. That may be one of the reasons why just manipulating people with antioxidants doesn't necessarily produce the type of health benefits that we wanted. So I'm going to switch now and talk a little bit about some new takes on the endothelium and some differences in the way we think about things now. So we just talked about a model of blood flow recovery when tissue gets ischemic. And one of the things that happens during ischemic tissue is the endothelium responds with proliferation and migration to produce new capillaries. But this actually happens in a relatively toxic environment, right? It has to happen when things are hypoxic and when other cells are dying. So that means the endothelial cells need to be able to respond to stress. So we've also had a separate line of investigation about the type of stress pathways that protect the endothelium. And I won't go into too much detail, but there's a number of stress responsive pathways. And both in the endothelium and in other tissues, one in particular that caught our attention is called c-Jun N-terminal kinase. We're not going to use that word again. It's easily abbreviated as JNK, JNK. And one of the family members that we got interested in is the one that's least studied, which is number 3. Its tissue expression is a little different than most. And in fact, one of the things we found out during the course of the investigation is that its tissue expression is often most prominent in the central nervous system. And so we looked at this stress responsive pathway and how it might be involved or not in blood flow recovery. And the first thing we did is we actually looked at people. We took our friends from vascular surgery who were doing amputations, and we looked at muscle tissue that was both in the normal blood flow area, meaning above the amputation site, and tissue that was below the amputation site, using the same muscle, but at different sites. And we looked at this stress responsive pathway, and lo and behold, we found that this stress responsive enzyme, JUNC, again, was upregulated in the setting of ischemia, which kind of intrigued us. So could this be involved in the blood flow recovery process? So we went back to the model we just talked about. It was relatively straightforward for us to work with one of our colleagues and find a mouse that doesn't have this enzyme. And interestingly enough, when we looked at it, if mice didn't have this stress responsive kinase, we kind of got a backwards response, which is we thought it would be bad because the endothelium wouldn't do so well. But it turned out that the blood flow recovery was better, and it actually got better faster. And we'll be able to explain why in a moment. And that if we looked at how the endothelium was doing in the ischemic tissue, there were more capillaries, more blood vessels. So this really got our attention for 2 reasons. One, it was backwards, and sometimes backwards findings prompt your thinking to be more expansive. But the other was there are very, very few things that improve blood flow recovery. There's been a lot of studies done in angiogenesis over the years at strategies to improve it, either with medicines or with genetic manipulation, because we don't have good treatments for peripheral arterial disease. And none of them have worked. And there aren't too many manipulations that improve this process, but this one looked promising. So we ended up doing a number of experiments that told us maybe actually the action is not going on in the endothelium, maybe it's going on in the nervous tissue. And so we used some genetic techniques that we don't need to go into, where we could selectively get rid of this enzyme, this stress responsive enzyme, in either the muscle or the nervous system. We actually checked the endothelium and it's not expressed there, and I won't show you that data. So we could knock it out of each place. And it turns out if we knocked it out of the skeletal muscle, we didn't see much of a response. But if we knocked it out of the nervous tissue, the peripheral nerves, we got an accelerated blood flow response. And we did a number of other studies to molecularly identify how this happens, which I won't bore you. But the final model is, I find, pretty interesting. And it involves neuroendothelial influence. And the model goes a little bit like this. In the normal setting, you have peripheral nerves that innervate your muscles, and they have an effect on your capillaries. You know, your blood flow in the muscles is due to the capillaries, and that's regulated in large part by the endothelium. When you have ischemia, your nerves also get ischemic. They sometimes get dysfunctional as well because of the ischemia, and their ability to help contribute to growth factor generation is limited. And we were able to demonstrate, which I won't show you the data, that if you take nerves and isolate them and look for growth factors that affect blood vessels, they're sky high. And by not having JUNC3, the nerves actually survive better. They're more functional because this is also a pathway that's involved in apoptosis. And in fact, that extra growth factor production, because you're preserving the nerves, stimulates better blood vessel development and better recovery from ischemia, suggesting that nerves have a lot more to do with blood flow recovery than we thought. So our data makes us believe that peripheral nerves are actually a key to the key determinant of how blood flow recovery occurs in the setting of ischemia. And we believe the mechanism is related to the fact that they're an important source of growth factors that help preserve blood vessels and stimulate them to grow. And one of the reasons that we may not have done so well in angiogenesis therapy is we may have been looking at the wrong target tissue. We've been trying to flog the blood vessels to do better, but directed no attention at the nerves whatsoever. And in fact, if you look at early studies of diabetic peripheral neuropathy, which is a well-known condition that affects blood flow in the limbs, one of the first things that happens is nerve degeneration. And it could be that nerves are an important maintenance component of blood vessels. And don't forget, in development, as you learned in anatomy, it's nerve, artery, vein. They're all next to each other. So we're going to keep developing this story, but it's become fascinating to think that if we can find therapies that will preserve nerve viability, particularly in the face of things like ischemia, that we may actually be able to do a better job at improving blood flow than we have in the past. So what other new takes might we have on the endothelium? So I'm going to switch gears a little bit now and talk about some genetics and some work that's done by some investigators that we have at the Brigham. So in addition to the effects on atherosclerosis and cardiac events, endothelial cells are also gatekeepers for things like cholesterol deposition and even transport into vessels. And genome-wide association studies have identified a number of coronary artery disease risk genes that have facilitated investigators like Pradeep Natarajan at the MGH to develop a polygenic risk score for coronary artery disease. And that risk score is known to provide additive information to traditional risk factors. But it can also be leveraged to study distinct biologic pathways that might contribute to coronary disease. And one of the investigators, Raj Gupta, had already done a beautiful large study in Nature where he perturbed every gene pathway in endothelial cells and found out which ones impacted cell function. And he was able to use that information and information from the literature to think about the process. Could we generate an endothelial cell risk score to identify lipid and non-lipid risks for coronary disease? So as I said, this work has been done by two of our younger faculty, Raj Gupta and Nick Marston. Raj is a basic science genetics person, and Nick is an investigator in the thrombolysis and myocardial infarction group. So he's a clinical investigator. So what they did is they looked at the GWAS studies from the Cardiogram Plus C4D consortium, which is a European-based consortium that collects DNA from people with early coronary disease. And they also looked at the Million Veterans Program and people with CAD. And we're able to find 35 single nucleotide polymorphisms that were linked to endothelial function. And they also were then, as controls, they developed a polygenic risk score for LDL and one for non-endothelial cell activity. So the 35 SNPs were things that were linked to endothelial function. So that's the endothelial cell polygenic risk score. And then they tested whether it has any impact on cardiovascular risk, initially using the UK Biobank. And for many of you, you probably understand the UK Biobank is a really large study in the UK where they've sequenced everybody, and they have a huge wealth of both follow-up information because of the National Health System, but also imaging studies, et cetera. And then they went and looked at some of the other trials in terms of validating it. So what did they find? They found that if they looked at the endothelial cell polygenic risk score, they were able to detect an increased hazard ratio for coronary artery events of about 44% with the endothelial cell polygenic risk score. And to give you an idea of what that magnitude of risk is like, shown on the same panel are what the hazard ratios are for LDL cholesterol, systolic blood pressure, CRP, and hemoglobin A1C, diabetes. Looking more carefully, they found that there was a strong interaction between the LDL cholesterol and the endothelial cell polygenic risk score, such that the endothelial cell risk score was much more powerful with higher LDLs than with lower LDLs, suggesting that it identifies a group of people who benefit more from LDL cholesterol lowering than others. And to look at that, they went into two clinical trials that had been done. One is called the Jupiter trial, which was a study done by Paul Ridker. That's a study where individuals with relatively controlled LDL cholesterols were tested for their CRP. And if their high sensitivity CRP was elevated, they were put on a statin. And lo and behold, the overall finding of the study was that it worked. And statins actually improved cardiovascular outcomes even in people whose LDL cholesterol was controlled. And that is the reason behind our concept of residual inflammatory risk for patients. So shown on the left panel is the Jupiter trial, and in the blue are the people who were on placebo. So they had higher cholesterols because they weren't on statins, and the endothelial cell polygenic risk score was very profound in terms of being able to identify who was going to have coronary events. If you had a low endothelial cell risk score, you had lower events, and if you had a high risk score, shown on the right side of that graph, you had much higher events. But if you were on statins where your LDL cholesterol was locked down, there was actually not an impact. And then on the right is a different LDL manipulation, which is the Fourier trial. And the Fourier trial was a trial of PCSK9 inhibition with evolocumab done by the TIMI study group. And a similar finding in the blue, without being on treatment, an increased endothelial cell polygenic risk score predicted an increased event rate, but not so much when you are on evolocumab and your LDL cholesterol was locked down. And in fact, on evolocumab in the Fourier trial, a lot of the median LDL cholesterol was in the 40s. And some people had LDLs as low as 25 milligrams per deciliter. So some take-home messages. Endothelial cells control a host of homeostatic functions beyond vascular tone. Endothelial function is influenced by both genetic and environmental factors, and it's a gateway to vascular disease, and we're still learning about its genetic contributions even today. I'd like to acknowledge all the people I've collaborated with in the past and members who've gone through my lab. Those in red, I've directly talked about their work here. The others have contributed in other studies. So thanks very much for your attention, and I'd be happy to take any questions.
Thank you, Dr. Keaney. That was a superb grand rounds in every sense. We appreciate it. I'm very intrigued by the neuronal regulation of the heart. And I'm wondering, is there anything that can be learned from heart transplants where you take a heart out without the nervous system necessarily connected to it? And yet, do you see any repeat changes in the coronary artery disease that the original heart had? Now, I know it's a complicated situation. There's stem cells involved and everything, Josh, I get it. But in addition to that, however, is it more the local nerves that are the issue, or is it are there more central nervous innervations that are responsible for the coronary artery health?
It's a great question. I have this. I don't want to get too close to you in case we get feedback. So, so fantastic question. So it turns out that people who get a heart transplant get transplant arteriopathy. Their coronary arteries get smaller and smaller, and they develop intimal hyperplasia. Now, for many, many years, that was just simply attributed to the fact that you're in an immune activated state and that you're giving people immune suppressives, and that actually often that makes their cholesterol profile a little bit worse. But until we came across this, no one actually thought that maybe the nerves have something to do with maintaining the health of the blood vessels. And there's actually really good basic data that the nerves, that the endothelial cells talk to the myocytes for sure, because they release a group of compounds called neuroregulins that are important in the health of cardiac myocytes. So it's not that crazy to think that there may be substances elaborated from the nerves in the cardiac tissue that actually help maintain the health of the coronary arteries. But that has not been investigated to any great degree.
Ask your question into the microphone so the people online will be able to hear it.
Thank you, John. I'll just echo what Roy said. That was a superb lecture. My question relates to clinical applicability, specifically in testing. Do you think there's a role for measuring endothelial function and dysfunction in the clinic? Can that help the clinician guide therapy and identify patients who need more intensive therapy, for example?
So the answer is yes, but with a caveat. And the caveat is that our current methods for measuring are very technically operator dependent and not readily portable. And in fact, people who are in lab medicine will tell you one of the critical features of a new lab test is how easily other people can do it without being married to it, like somebody who developed the test. And measuring, for example, FMD, as your lab does, it takes a while to get it down, and each lab is a little bit different. What I'd love to be able to find is this elaborated substance specifically from endothelial cells that you could measure circulating in blood that would be a barometer of the health of the endothelium. And to be honest, that hasn't been prosecuted very much yet. But that to me would be the best way to be able to do it, because then it would be much more portable between labs and around the world, as opposed to one person does flow-mediated dilation one way and one person does it another way, and that they're not directly comparable.
John, thank you so much for being here with us today. And we're so thrilled and happy to be with you in this, as you navigate through this amazing journey through the physiology and pathophysiology of endothelial disease. I think we've got enough understanding of the physiology and pathophysiology. There's still things to learn, but we have a good understanding more or less. Question is, we diagnose abnormalities, disease. What do we have for therapy? Right now we have RAS inhibition, statins. This is old school medicine. Do you have anything in the horizon coming to fix the problem that we now better understanding?
So in terms of endothelial specificity, I can't say yes yet, because we actually just now, as you've seen with the study, starting to prosecute some of the genetic components of the endothelium. But looking down the road, the new things that I see, and I kind of scout them out as part of my New England Journal job, are a more focus on different lipid parameters than we did before. And the one that appears to be the favored target that everybody's working on is lipoprotein lipase, which is very involved in processing of triglycerides. And for those who don't remember, triglycerides in heart disease have had a storied past, because if you correct for diabetes and a few other things, a lot of the associations go away. But it turns out that specific types of triglycerides that are the product of lipoprotein lipase are important, because we now know from genetic studies, which I didn't show here, that if you have abnormal function of lipoprotein lipase, your risk of heart disease is higher. And that if you have a genetic upregulation of lipoprotein lipase, your risk of heart disease is lower. And there's a number of factors that stimulate or inhibit lipoprotein lipase, and genes in those pathways also affect heart disease. So now there's a race to come up with inhibitors of that pathway, some of which are available. for some of the cofactors that I'm sure we're going to read a lot more about in the next 5 years.
Can we,
Dr. Lakakis, if you want to unmute yourself and ask your question.
Thank you so much. You mentioned about the role of NO, the synthase plays, and I was thinking if there is any role for riociguat that increases the activity of guanyl synthase, or tadalafil that blocks the phosphodiesterase in the health of coronary vessels.
So, well, clearly in pulmonary hypertension, the answer is yes. But in terms of cardiovascular disease, there hasn't really been a strong signal. One of the issues with translating signaling knowledge into medicines is that when you're somebody who studies signaling, it's like real estate. The thing you think about the most is location, 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 because a lot of signaling is in short distances from one cell to the one next to it, which is very difficult to mimic by just giving a drug that blankets the entire body with stimulation of a pathway. So in terms of coronary disease and hypertension, those two haven't had as much success. It's mostly been in the pulmonary circulation, where it appears to be even more sensitive to the cyclic GMP pathway than other vascular beds.
Thank you.
okay,
Enjoyed your fantastic talk. So we all know that superoxide is a bad guy, and by interacting with nitric oxide to produce UNO, UNO is even worse. You elegantly showed that hydrogen peroxide could increase the bioavailability of nitric oxide. Can you elaborate on the mechanism by which it does that? Thank you.
Yeah, so I didn't want to bore people with a bunch of Western blots, but we were able to demonstrate it changes the phosphorylation status of eNOS into a more stimulatory state and allows it to elaborate. It has more catalytic activity and elaborate more, That's the simple answer. Later on, we can discuss the residues that are phosphorylated and dephosphorylated, but that's the reason.
Well, I want to once again thank our speaker for an absolutely superb grand rounds in every sense of the word. I want to thank our donors very much for making this happen for year after year. And I want to remind everybody, our CME system is down at the present time. However, you will be personally emailed the link for the CME when it comes up again. Francesca knows everybody who's here in the room and everybody who's online, and you will get the link. I want to thank everybody again for coming today to Grand Rounds, and wish you all a good week, and we'll see you next week. Thank you.